Hello everyone, now we will talk about the renal system. As always, what we're going to do is that summarize these big case scenarios into small words, which are the most important words that guide you to the right diagnosis. Alright, so if you see a 42-year-old man comes in with weakness, arthralgia, okay? There's a leg pruritic rash as well. And then you check the labs, there's protein in the urine. The complements are a little bit low, rheumatoid factor high. And transaminitis, you see transaminitis. And creatine 1.7. There's red blood cells and protein in urine. And they ask you, okay, what's best next step to establish diagnosis? You want to do viral, hepatitis, panel, serology, okay? Why? Because this is called cryoglobulinemia, associated with hepatitis C. And there are two types. Type 1 is the lymphoproliferative or hematologic. You have multiple myeloma, it can be asymptomatic or can cause hyperviscosity syndrome like blurry vision, thrombosis, rhinoid phenomena, livedo reticularis, and complement level would be normal. That's type 1. Type 2 is the mixed, like type 2 and 3, hypersensitivity. So usually this is associated with chronic hepatitis C virus or HIV or SLE. It could cause fatigue, arthralgia like in this patient, cause renal glomerulonephritis, hypertension. It could cause dyspnea, pleurisy, pulmonary findings, could palpable skin purpura like this patient, what they have, and low C4. Okay, low C4 is also another clue that guide you to the diagnosis. Alright, so another interesting case, if you see a patient who's 26-year-old man comes in with diarrhea, okay, and then lower abdominal pain, and then you see platelet 55k, and then you also see creatine is 2.4. Okay, so what do you see? What are you noticing here? There is like abdominal pain, bloody diarrhea, and you have a thrombocytopenia and elevated creatine kinase, renal failure, thrombocytopenia, bloody diarrhea. What does that tell you? What does that ring a bell? What do you need next? And they ask what's the next step. So you need to know what's the diagnosis. This is most likely hemolytic uremic syndrome, so you know you want to do a blood smear to confirm it if it is or not, okay? But that's the job as a physician. You suspect, most likely diagnosis, and you treat it, okay? So symptoms, diarrhea, abdominal pain, vomiting, and then there is a triad, microangiopathic hemolytic anemia, hemoglobin less than 8, negative Coombs test, and there is schistocytes on peripheral smear, thrombocytopenia, platelet less than 140,000, and usually around 40,000, acute kidney injury as well. Okay, so these are triad, and then you can also have elevated lactate dehydrogenase, elevated bilirubin, decreased haptoglobin, which is expected where there is a hemolytic anemia. Okay. All right. Now, how do you treat somebody CKD hypertension? Best next step, you want to do lisinopril. It's shown to be helpful, like ACE inhibitors, helpful, like treat hypertension. Especially if they have like kidney disease or they have renal artery stenosis as well. Okay, so renal artery stenosis. Okay, hypertension, renal artery stenosis, because this way inhibit the as inhibitor. So renal artery stenosis could increase the renal angiotensin aldosterone system, and this lisinopril inhibit that. Okay, so it's helpful. You know, it's as efficacious as angioplasty. And if that doesn't help, then you do angioplasty. Because if you don't treat it, it causes recurrent flash pulmonary edema, recurrent hypertension episode, and that kind of things. Okay. Now another case is kind of interesting. Somebody had chronic kidney disease like creatine 1.5 and hypertension. Okay, so what do? You give lisinopril to treat hypertension. You can do that, and then 2 weeks later the patient developed creatine like of 1.8. So you see increase. Now they tell you, okay, what to do. Do you stop the lisinopril or you continue? The answer is continue and repeat test in 2 to 3 weeks. Okay, so continue lisinopril in this case. Okay, especially if they're diabetic, you know, you really need lisinopril or angiotensin receptor blocker, and that's expected. You have 30 to 35% bump of creatine from baseline, and that's is acceptable. Should not discontinue the therapy. Okay, it's very helpful, like for proteinuria, you know, especially if they're diabetic hypertension. You know, lisinopril is a good drug. You know. Now you have 75-year-old comes in like he has CKD, GFR talking like 7. It's like end stage renal disease, right? So and live in the nursing home. This lady, okay, live in the nursing home. 75-year-old lived in the nursing home, and no activities whatsoever. Okay, in bed, and they just do all the activities for her. So what the question is asking, what do? You do hemodialysis or what other things, or palliative? This case, you know, honestly, palliative would be better, you know, for her. She's not having any quality of life, and then you do add dialysis to that, you know. She's having ulcer, crackles, you know, things can go downhill really fast, okay. Now you see somebody comes in because of so they have 63-year-old comes in because of frequent urination, okay. So you see lung exam shows bilateral crackles, okay. Creatine is like 1.1. There is diffusely enlarged prostate, you know, enlarged prostate, okay. So the trick here, so somebody have BPH symptoms and they have heart failure symptoms. So patients has bilateral crackles, JVD, leg swelling, you know, and the enlarged prostate. They came in because of increased urination. So the answer is, what do? Do you treat the prostate? You do doxazocin or tamsulosin, like you do doxazocin for the prostate, or you increase the Lasix dose? What do you do? That's what they know. Which one you need to treat better more? Is the prostate or the heart? Heart is obviously need more care and treatment, so you increase the Lasix dose. Actually, you need to get rid of more fluid in this patient. Alright, now somebody have like CKD and you need angiography for peripheral arterial disease like claudication, okay, and they tell you what to do before contrast. You hold NSAID, hold ibuprofen before giving the contrast. And that brings us to the discussion of the contrast-associated acute kidney injury. So creatine elevation like 24 to 48 hours after arterial contrast administration usually cause that, and then gradual return to baseline within 3 to 7 days. And risk factor, somebody who have chronic kidney disease, particularly if they're diabetic, nephropathy, somebody high contrast load, somebody who's hypovolemic or using NSAID. The reason, because it causes prerenal vasoconstriction, and sometimes contrast causes direct tubular toxicity, so it could bump up. I've seen patients like creatine bump up a little bit and then gets better and so on. The diagnosis is clinical. You don't need to do a biopsy. You can do fractional excretion of sodium, less than 1% would be there. You can look at the urine under microscopy. You see muddy brown granular cast, and you see patchy necrosis of renal tubular cells on biopsy. Okay. How you prevent it? You optimize renal function by 0.9% saline to give them fluid if they need. Hold NSAID and use lowest volume of contrast agent possible. Okay, so hydrate them few hours, put them to contrast, hydrate them a couple of hours before and after the contrast. Okay, hold NSAID. That's how you avoid contrast nephropathy. All right, now you have a guy, 41-year-old man, came in with acute flank pain and dysuria, okay, and there is CVA, tenderness, you know. Urinary catheter is placed and produce 10 ml of urine during 6 hours of observation in the emergency room. what's best next step that you need to do for this patient? Severe tenderness, and the patient. The other thing is the patient is having HIV and was started on sulfadiazine permethamine for toxoplasma prophylaxis because the patient has HIV. Okay, so you need to do prophylaxis for toxoplasma. Okay, so what do you do? Best next step, you do urinalysis for crystals. Okay, you want to do urinalysis for crystal because this is could be a crystal induced kidney injury. Usually happen with acyclovir, sulfonamide, methotrexate can cause that as well. Ethylene glycol protease inhibitor, uric acid from tuberous lysis syndrome can cause that as well. Usually can be asymptomatic, but sometimes can have hematuria, pyuria, and crystals, and increased risk with volume depletion or chronic kidney disease as well. And usually AKI less than 7 days from starting the drug. You have to start the drug and then you have AKI. So the management for that, you discontinue the drug, give them some fluid, give them Lasix, you know. That's the management. This is crystal induced nephropathy. So you gotta know how to deal with that situation. Okay. Okay, now this case, you see 42-year-old man had transplant, kidney transplant, renal transplant, okay? And then, obviously, if you are on transplant, what do you need to be on? Okay, you need to be on some medications like tacrolimus, okay, mycophenolate, you know, to avoid rejection, on top of the sinoprelum, lodipine, all that good stuff. So you need to be on those medications. So somebody had transplant, okay, and then they develop their creatine. Now they come after transplant and starting this medication. Lab shows creatine is 2.2, and they will tell you why. Why did the patient have renal failure? Okay, obviously it's medication toxicity. Okay, so because there are medications that interact with tacrolimus and cyclosporin. Like if somebody started on macrolide, like sometimes they bring it the way they ask the question. Somebody had transplant, tacrolimus, mycophenolate, been on it for a very long time, and then like for some reason they needed to be on azithromycin, macrolide. They need to be on antifungals, diltiazem, verapamil, amiodarone, grapefruit juice. All of these could increase the drug level and cause toxicity. Okay. There are others that decreases the drug of tacrolimus and cyclosporin, like nafcillin, rifampin, carbamazepine, phenytoin, and phenobarbital, and St. John wort. This decreased level of cyclosporin and tacrolimus. Okay. So these medications, when the patient taking them for a very long time, had fungal infection, needed to be on azole treatment, increased toxicity causes renal damage. Okay. So this is how they can ask, causes decline in GFR. Other things can cause like hyperkalemia, hypophosphatemia, hypomagnesemia, hypercalciuria, can cause possible metabolic acidosis. So this can be serious. Sometimes you even need biopsy to rule out acute rejection in this case. Yeah, so you may need to involve nephrologists as well, okay? And some patients can develop residual chronic kidney disease from that. Alright, now another case is easy. 65 with hematuria. Then best next step, you do cystoscopy, okay? Even if they tell you negative malignant cell and all of that, you know, you need to know how to deal with hematuria. This is important. You see that all the time, you know. So what could be, how do you deal with hematuria? Okay, so if somebody have asymptomatic, so this is especially if it's painless hematuria, okay, this is what you would be scared. Asymptomatic hematuria on dipstick, you do microscopic urinalysis. If it's normal, you just repeat urinalysis in 6 months. If it's normal, routine follow-up. If there is still hematuria, you evaluate for other causes that we're going to talk about. So, if there is in the hematuria, if there is RBC cast, if there is a proteinuria, if there is evidence of kidney disease or hypertension, you evaluate for renal diseases, okay? But if there isn't any of that, there is just microhematuria, just RBC, okay? with risk factors like somebody smoker or suspected urologic malignancy, then you do cystoscopy, imaging, urine cytology recommended. If there is no risk factors but hematuria in 2 out of 3 samples, you still do cystoscopy, cytology, and imaging. Okay. So pretty much hematuria, if there is suspicion, there's no cast or significant or kidney disease, then what you would do if there's no cast or kidney disease, what you would want to do, you just rule out cancer, bladder cancer. So you follow up with your urologist to rule out bladder cancer. Okay, now we have another 70-year-old man came in with a bladder problem, continuing bladder problem. So what is the problem that she's having? Okay, the bladder problem is like urge to urinate, So this is urinary urgency. So they tell her, okay, what do you treat her? You treat her with anti-muscarinic agent, okay? Basically, you inhibit the parasympathetic response to the bladder so that you stimulate the sympathetic works and empty the bladder. So this brings us, like, there are different types of urinary incontinence. There's stress when there's decreased sphincter tone, the screw is like loose, and there is urethral mobility. You have leakage with coughing and sneezing and lifting. There's urge when there's detrusal overactivity. You do sudden overwhelming urge to just go to urinate. And there's overflow, like when you have the bladder impaired contractility, or there's bladder obstruction, the screw is too tight. This patient have incomplete emptying and persistent involuntary dribbling. That's how you differentiate between these. Alright. Now you have somebody who has alkaline CKD, okay, and then you check their phosphate. Phosphate is like 5.1, okay, and then the question is, what's the benefit of adding cinacalcet in this patient? Cinacalcet benefits, okay, what do you need cinacalcet? So, or when do you do that? Cinacalcet decrease the need for parathyroidectomy. Okay. So in this case, usually patient, like, you see the parathyroid hormone is like 700. They give you parathyroid hormone is high, phosphate is high, okay, and then calcium would be as well high. It's like 9.5. There is a fine balance. So the way you give cinacalcet to trick the parathyroid, that there is, because the calcium and phosphate that's present in the system, it's not enough to suppress the parathyroid hormone. So you give this calcinomimetic, but it's not calcium. So you want to give it to stimulate the parathyroid, to suppress the parathyroid hormone. So you decrease the need for parathyroidectomy, okay? So now that brings us to the discussion, how do you treat hyperparathyroidism in advanced kidney disease, okay? So if someone, first you check the PTH and phosphate. If it's above normal range, what you would do, you do dietary phosphate restriction. So hey, eat less than 900 milligram of phosphate per day. So phosphate, the diet that limit phosphate intake. What if there is still, even dietary fails, phosphate still above 5.5? What would you do? You add non-calcium phosphate binders, okay? You do like cevilamir and lanthanum, okay? This basically bind to the phosphate, decrease risk of hyperphosphatemia, okay? The body is in fine balance, so you want to keep everything in its right level, okay? So okay, you do that, there's still parathyroid hormone still elevated. Okay, now in this case, the management is gonna be different, okay? If the calcium below 9.5 and the phosphate below 5.5, in this case you want to add vitamin D or synthetic analog. This means you need more calcium, right? So you give vitamin D to get the more calcium. But if the calcium more than 9.5 and the phosphate is more than 5.5, this means you have enough calcium. It's just the parathyroid is not responding well to it. You have enough calcium, so what you do, just give calcinomimetics, which is cinacalcet. Okay, so that's our discussion for the chronic kidney disease and cinacalcet. That's kind of important, because if you give, like in this patient, like let's say you don't give calcinomimetic, thyroid is going to be high. It's going to increase the bone turnover and causes decrease bone mineralization. It's going to degrade the parathyroid, going to destroy the bone and increase risk of fracture. That's what it's called, osteitis fibrosa cystica. Okay, so this one, if you don't give that cinacalcet, the parathyroid stays high. Okay, what if you give vitamin D and then parathyroid is low, but you give a lot of vitamin D and the calcium will go high, and then you suppress the parathyroid, so the parathyroid drops significantly? This is gonna decrease the cellularity of the bone, because the parathyroid, you need the right amount of level. You don't need too high, you don't need too low. This is gonna decrease the cellularity and the metabolism of the bone. Parathyroid metabolize the bone, strength of the bone. So if it drops, the bone is going to be weaker. It causes adynamic bone disease, because there is no movement in the bone that needed by the parathyroid. So also increases risk of fracture. So that's why it's important. It's a challenge to keep a fine balance for the phosphate, calcium, and parathyroid hormone in patients with a chronic kidney disease. Okay, so another case is interesting that we're going to talk about, kind of like to solidify the question that we had. So let's say they give you 60-year-old, came in with leg pain, okay, and then you find a fracture, okay, stress fracture. You do the labs, you see CKD, you see the parathyroid hormone, 26 is very low. The previous one was 700, this one's low, 26. And 25 vitamin D level is 60. Normal is 20 to 65, 25 to 65. So this is on the higher side, okay? And then 25 vitamin D is like 40. It's kind of in the between, okay? So what is that? And they tell you, okay, what do you do next? So this is one you have, and the calcium is like 10.3. Okay, calcium 10.3. So you have enough calcium, you have enough vitamin D. So the best thing to do is discontinue vitamin D, because we said we want fine balance. Here, if you have the suppressed parathyroid hormone, you're gonna develop a dynamic bone disease. Like you won't have, so the parathyroid, you need it at the right level, that it's not stimulating the bone too much and not too little. You want it the right amount of osteoblast. Okay. If the parathyroid hormone more than 450 is very high, this can activate osteoclast more, cause elevated alkaline phosphatase, and causes fractures, called osteitis fibrosa cystica. And the treatment for that, you want to decrease phosphate restriction. You decrease phosphate diet. You do phosphate binders. You give vitamin D analog, calcinomimetics. You want to do everything you can to suppress the parathyroid hormone. But what if the parathyroid hormone is below 100? This is nobody's gonna stimulate the osteoblast, okay? Or nobody's gonna stimulate the osteoclast as well, okay? So the bone metabolism is gonna be depressed. So what you wanna do, you wanna discontinue vitamin D, like in this case, discontinue calcitriol, okay? Discontinue vitamin D. Switch to non-calcium containing phosphate binders, okay? And use low calcium diacylate, okay? That's the deal here. It's kind of the trick. It's very important to know that. Okay, so you may ask me, how does the kidney related to this kidney here, related to the parathyroid glands, it's like right behind the thyroid. How does that relate to that? It's interesting. There is a magic connection. So what's the function of the kidney? Filters the blood, right? One of the other functions is like produces vitamin D and filter the phosphate. So if it doesn't filter the phosphate, where does the phosphate go? It stays in the body, right? It has to go somewhere. So it stays. The serum phosphate will go out. And the vitamin D will go down because it doesn't produce vitamin D, right? So calcium absorption from the gut is going to go down. So you end up in having low calcium, high phosphate. So low calcium, high phosphate, thyroid, parathyroid hormone can detect that. Okay, there's low calcium. Okay, let me go up. Let me oversecrete to stimulate the calcium. Where is it going to bring calcium from? You're going to bring it from the bone, and you end up fracturing your leg. And we don't want that, okay? So that's kind of the interesting dynamics here. Alright, now this is another easy case. You see 31 women with flank pain and hematuria, and then scattered small pits on her teeth. CT abdomen shows 10 by 13 centimeter mass in left kidney, and they want to know diagnosis. Which one that causes pits on the teeth, kidney mass? This is tuberous sclerosis complex. Okay, this is just something you need to remember. Okay. Other features can cause ash leaf spot, hypopigmented macules, causes brown fibrous plaques on the forehead, angiofibroma, causes glioneuroma, hamartoma, subependymal nodules, seizure, cognitive deficit, renal angiomyolipoma, retinal hamartoma, pulmonary lymphangioliomyomatosis. This is a bunch of weird stuff, you know. Just know this is a case scenario example, okay? Okay, another interesting case. You see 36-year-old woman, okay? Came in because of weakness, okay? And then so you do labs. So labs showing potassium 3.1, okay? So there is some hypokalemia. You ask the patient, is there any vomiting? Is there any, you use diuretics, any of that cause hypokalemia, okay? She says, no, there's nothing. So you check urinary chloride, that reveals the truth. Urinary chloride on 2 occasions. One time becomes 15, another time it's 65. So this is discrepancy between urinary chloride suggests, and they tell you, okay, what's the diagnosis? Why is that? How do you find the diagnosis or best next step? This is diuretic abuse. So you want to urine screen for diuretics. Okay, why? Because the chloride is going to give you the answer. If the chloride more than 20, urine chloride more than 20, this means maybe there's diuretic abuse. Okay. Now, this another case is kind of high yield as well. Like, so if you see a 35-year-old woman come in with headache and sodium of 119, okay, and they ask you what's the best next step. So sodium, this is pretty low, so you can do 3% normal saline, okay. This is infusion pump. You can do 100 cc. This is gonna help the symptoms, okay. So if somebody have acute hyponatremia, like less than 24 to 48 hours, you do hypertonic saline if symptoms there. But if somebody have a chronic hyponatremia, hypernatremia defined less than 120, okay. Chronic hyponatremia, hypertonic saline if severe symptoms, like if there's seizure, if there's coma, okay. Because our goal here is to quickly increase the sodium by 4 to 6 MEQ in the first few hours, but you don't want to exceed 8 MEQ in 24 hours, okay? So that's the goal. You usually give 3% normal saline and just watch. Even if there is intracranial tumor or traumatic brain injury, then you need that, okay? Okay, this case, this is an interesting case. So 44-year-old woman on lithium. She really needs the lithium because of bipolar. She came in because of frequent urination. You kind of see where this is heading. Okay, so now you're smart. You know what to do. You check urine osmolarity. It's 300. So okay, after water deprivation, this one after water deprivation. Okay, still like 300. Okay, so now what you want to do is that you give DD AVP. You give DD AVP. After that, you see not much change. Usually supposed to, if it was central, if there was like deficiency in ADH, when you give the ADH desmopressin, usually should get concentrated, like increase to 600 or so. But this one, there's not much change. This means there's diagnosis of nephrogenic diabetes insipidus. And then they ask you what is the treatment for that. Treatment is amiloride, okay? Because if you can't stop lithium, if it's needed, then just to give amiloride, okay? Now this brings us, how do you know, like how do you to do the water deprivation test? Kind of explained it here. So you give no water for 2 to 3 hours prior to the test, and after that you measure urine volume and osmolality every hour, and then you measure serum sodium and osmolality every 2 hours. If the urine osmolality increases more than 600, this is primary polydipsia, that's it. You stop the test, you don't need it. But if it's still low, okay, you repeat it on 2 to 3 consecutive hours. You make sure if there is still if the plasma osmolarity more than 2.295 or plasma sodium more than 145, okay, then in this case, and still urine osmolality is low, you administer desmopressin, okay, and then you monitor urine osmolality every 30 minutes for 2 hours. If the urine osmolality increase, this is central diabetes insipidus. If it does small or no change in urine osmolality, this is nephrogenic. How do you manage nephrogenic? You give thiazide, amiloride, salt restriction as well, okay, or stop the lithium if you can, okay, but if you can, that's what you do, okay. Now this one, asymptomatic blood urine, you do best next step cystoscopy. It's important, you gotta do that, you know. Now someone who have dysmorphic hematuria and dysmorphic red blood cells, so what do you do? Hematuria and dysmorphic RBC, what's best next step? This one you do quantitative assessment of GFR and protein urea, okay. And you would say, why do you need that? Because this one is most likely IgA glomerulonephritis. You see 1 or more episodes of gross hematuria after upper respiratory tract infection. You can see microscopic hematuria with the protein urea on incidental urinalysis without symptoms. You can present like this, or you just can have nephritic syndrome, progressive to glomerulonephritis. So you want to have a quantitative assessment for this patient, okay. Now you have another patient who, like 80-year-old with fatigue, nausea, dizziness, you know, taking hydrochlorothiazide, and they ask you what could be the diagnosis. This patient could be HCTZ. It's causing hyponatremia. Hyponatremia. So what you want to do? You want to stop hydrochlorothiazide, give them some fluid. All right, let's review. We talked about hyponatremia. We talked about IgA nephropathy, glomerulonephritis. You know. We talked about cystoscopy. We talked about water deprivation, nephrogenic diabetes, amiloride, 3% normal saline. We talked about urine screen for diuretics. We talked about tuberous sclerosis. We talked about discontinuing calcitriol, and decreased need for parathyroidectomy, benefit of cinacalcet, antimuscarinic for stress and urgent incontinence. Medication toxicity, tacrolimus can cause that. Crystal, if there is permethamine, there's crystal nephropathy. Cause kind of like renal stone symptoms. Hold NSAID before contrast. And increased Lasix. Heart is more important than prostate. Palliative care. If somebody like ability to move and stage renal disease. Lisinopril continue if there is a small bump in creatinine is expected. Lisinopril for renal artery stenosis and renal hypertension. Viral hepatitis panel is recommended if there is low complement, transaminitis, and some fatigue or arthralgia. Okay, and that summarizes our discussion for today. Thank you so much for listening.